Vasuji, can you start the things?
It is. We are live now.
You are live, huh? Okay. So speaker. Mic இது audio connect பண்ணுங்க இதுல இருந்து. மைக் எங்க இருக்கு?
இப்போ பேசுங்க.
மைக். செக். செக். ஆமா. சரி. சார் நீங்க அங்க இட்ஸ் ஆல்ரெடி இன் லைன்ஸ்.
Can we start from that also?
Yes. So just 1 minute. Yes, we can start from this. It's already.
Good afternoon to you all, dear students, those who have logged in. So we welcome you to the next edition of the MRC ROC. So as you all know that this institution, the legacy is the oldest medical college, and we are trying to share all the clinical material knowledge, what we can do. So once in a month. And this month it is going to be a discussion on the hip joint and another short case. So for this program, I invite Professor Balaji, who is the head of department, who is the head of department of Balaji Medical College, to this meeting. A few words.
Very privileged for here. Someone will discuss. Professor like what I do. This really has been going on for a long time. So I've been seeing, and it's really picked up the whole levels. So last month we had this the same session. So we had a topic with Balaji and MMC for getting book appreciated by our whole graduate. I wish him also to continue this program so that it is continued even after this term. It's going to be very useful for the postgraduates work. So it's going to be coming.
So over to the president.
Yes.
Dr. Kavyani, sitting at both sides from another. Speaking of your name, a businessman by profession from number 2 came to us with complaints of right limb shortening for 14 months and inability to walk without walker support for 14 months. History of presenting illness. Patient was apparently normal 14 months back and sustained a road traffic accident and sustained injury to the head and right hip, for which patient was admitted in a hospital and treated with ventilatory and intensive care for the head injury and POP application for the right leg for 1 month. After which patient was discharged and went to another hospital where they had advised contraction with weight application for right lower limb for 2 weeks. Patient did not tolerate after 2 weeks and hence it was discontinued. Patient was then advised walking with walker support and physiotherapy. Patient now presents a history of right limb shortening for 14 months, not associated with pain, and inability to walk without walker support. On inability to walk without walker support, he sustained injury once, and since then patient is unable to walk without walker support, but it is not associated with pain. Patient has inability to squat, to sit cross-legged, and difficulty in walking and climbing stairs for the past 14 months. No history of hip pain or knee pain, no history of back pain or neck pain, no history of early morning stiffness or small joint pain, no history of eating rise of temperature, no history of loss of weight, loss of appetite, no history of chronic cough, no history of burning intuition, no history of redness of eyes, no history of weakness or numbness of lower limb, no history of recent admission for COVID. Past history, history of trauma 14 months back, following which patient developed the following complaints, no history of similar illness in the past. Personal history, no smoker and alcoholic, and unknown case of seizure disorders on medications. Family history, no similar complaints in the family. Some
So, for trauma history, I would say that also the because this is obviously yeah.
So summarizing my history rating, most likely it is a right side pathology, etiology disposed from it.
Right. So you have ruled out all the process that is following trauma. And this disability is that it's not able to walk without walk support. That is not able to squat or walk it. So from this history, what do you think was the part of most traumatic and most difficult?
Non-union or non-union also fraction.
Why do you think it is not?
Because it is not associated with pain.
Okay. Why can't it be a malady?
Patient is not able to wake that on the.
So, a mark-related fracture in 14 months, patient definitely, even with the limp, he will be able to stand and walk. Walk again once, other than stand and walk. So, most likely that the fracture has not been healed completely. So, it might be a non.
If they are not in pain when they walk, but we are not doing anything. They are in pain or not? You said if the other person walk, he is not able to walk. Walk. It's a lot in it.
Pains.
But sure there's no pain at all. If it's a lot in it, put back. I don't know, of course. That, as I said, there is not going to be any pain. You can walk. You can walk in a dignity to walk. But you have to stop. Not even I think that. But it does. Okay.
On examination, general examination, patient.
No, sir, actually,
What happened to this camera?
recording is going on, sir, just for time being. Be done,
It is not connected.
not connected.
So, it is going to get connected. Because for the examination of the writing, we need that camera.
Yes,
Okay.
General examination, height and arm span ratio is 1:1. And the upper limb, upper trunk and upper segment, lower segment ratio is normal. Patient has no neurocutaneous markers and no ligamentous laxity. And head-to-toe examination, movements of the cervical spine is normal. Chest expansion is more than 6 centimeter.
Those things you can update at the end. Okay, general examination, if you are finished, that there is no ligamentous laxity or generalized findings, then you can come to the examination of the limbs. Yeah.
Examination of lower limbs. Examination, there is no exaggerated lumbar lordosis.
So in the examination, lying, standing, sitting.
Patient is unable to stand still. So first I examine the patient in sitting position. Sir. In sitting position, head in center, both shoulders at same level. There is no exaggerated lumbar lordosis.
Usually in sitting position, we don't comment with direct responses. Okay, in sitting position, both shoulders same level. Okay.
Then, at the level of the patella, we notice shortening of the right thighs.
Right, very good. So that is the only thing which you want to see. So in standing and sitting, if you want to make any difference, If there is any linear discrepancy, there may be a scoliosis, which on sitting the scoliosis will get corrected. That is what we want to see. So since here the patient is not able to stand, the shortening is not compensated. Sitting, both shoulders are the same level, spine is and right side metallized and possibly negative, meaning that the right shoulder is shorter than the level of the thigh. That's what you have done. Okay, we can go.
Examination, there is in supine position, there is no exaggerated lumbar lordosis. Bilateral anterior iliac spine appears at the same level, and right attitude of the right lower limb is in extension, knee in extension and external rotation, and foot and ankle in plantar flexion and lateral aspect of the foot touching the couch. And there is obvious wasting of the right thigh and the right calf muscles and shortening of the right lower limb. Then examination of right.
Okay.
Examination of right hip proper on inspection. The scar pass triangle. There is no fullness, no scars, no sinuses. Graded trochanter appears at a higher level, and there is no scars or sinuses, and no fullness, scars or sinuses in the posterior aspect and in the medial aspect.
So is it only at a higher level? Anything else you want to comment about the data? Yeah, you proceed. Okay, you proceed.
And on palpation,
So the greater trochanter, since the foot is touching the ground, but you are not able to comment on that. Okay, this patient should be lying this way. Right. Okay, yes, we go on. If it is difficult, then probably. Okay.
and on palpation, there is no exaggerated lumbar lordosis. Right anterior.
So how did you confirm that there is no exaggerated lordosis?
On insinuating my fingers, my knuckle did not cross the middle.
Okay. So you have to make sure, even in inspection, you are not able to see the light on the opposite side. Palpation, you have to make it a point. Because if the abdomen is flabby, your fingers may not go. So you have to insert beyond the flanks and then go upwards. Right? The knuckle is touching, the spine is touching the knuckle and preventing going further, then you have to make it. Oh.
On palpation, right anterior superior iliac spine is at a higher level. And scar pass triangle, there is no fullness, there is no swelling, no tenderness, no warmth. The greater trochanter appears at a higher, greater trochanter is at a higher level, and there is thickening and broadening of the trochanter in the anteroposterior and mediolateral aspect, and there is no petrochantric or bitrochantric tenderness.
Mediolateral aspect of the palpation. The trochanter. So don't say all those things. Palpation, it is thickened. So how did you find out that it's thickened?
Thumb and the
So thumb on one aspect and the fingers on another aspect. You see that the width is increased. So don't say specifically as mediolateral and posterior. So probably this is externally rotated. What you are seeing is mediolateral. Those things don't go into all those things. Okay.
then gluteal region, there is no swelling, there is no sinuses.
So in addition to being proximal like palpation, the trochanter.
The surface of the
No. Surface you said that it is thicker than
irregular
right? That you mentioned.
tenderness,
Is it tenderness or not tenderness?
not tenderness.
So any other aspect you want to palpate? Anterior, lateral, posterior, medial?
Anterior.
Yeah, medial, she said. Yeah, she said that. So the trochanter itself, in addition to being proximally migrated, has gone posteriorly also. It is shifted posteriorly also because you are not palpating the same. It is externally rotated, obviously. So that you will have to measure in the branch time also. Okay. Right. So in the trochanteric tenderness, is it trochanteric tenderness or is it transverse? You said it is tender.
Not tender.
Not tender. Okay. So when you say it's not tender, you have to specifically mention trochanter per se is not tender, which is called as the trochanter. Yes. And the other tenderness is white trochanter. Is it there?
No, sir, not.
What do you mean by that and how do you use it?
No, I just say,
Both trochanters, not either side. And both trochanters, you are transmitting the tenderness. So where all it will be painful? Which all conditions, the bitrochantric, the pertrochantric tenderness is not there. But bitrochantric tenderness, where all it will be painful? So you are transmitting the tenderness. So what are all the places where it can get transmitted?
You have the neck, you have the head, you have the joint, you have the everything is there. So the pathology of that area.
No, you need not go into the disease aspect. So any problem in the neck, any problem in the head, if there is a problem in the joint, if there is a problem in the chest, anywhere, you can elicit the tenderness by transmitting the pressure. Pressing the trochanter, you see that there can be a tenderness. Okay, so that is bitrochantric tenderness. But trochantric is whether the pathology is the trochanter itself. That you calculate is the thumb and index, the other fingers, and finding out whether trochanter is. Then you transmit it. That is called as the press tenderness, or it can be a bitrochantric tenderness. This is pertrochantric. This is bitrochantric. Right. Next.
vascular sign of nerves, bilaterally femoral pulse is equal in volume and time. Posterior aspect, there is no swelling, warmth, and tenderness. There is a healed scar over the gluteal regions.
Is it significant to this?
No, sir.
Not so.
In medial aspect, there is no swelling, tenderness, warmth.
So this vascular sign of nerve also, you have to say that you are talking about the anterior aspect. So anterior aspect, there is no warmth, there is no tenderness. Femoral pulse is felt equally on both sides. Don't say each other.
Okay. Where do you not feel that pulse? There are both sides.
Dislocation.
Dislocated as well. What is the condition when the head is not there in the soft? What is dislocation? Soft head or a very small head, like falling infections kind of. What are the dislocated? It is not there or just level. And there's some problem with vascularity. So there's an occlusion of the vessels like close to the vessels or service. Those conditions again you cannot do this. This is one of the important conditions.
Assessment of fixed deformities. There is no coronal plane deformities. Sagittal plane deformity. There is a
No, you said that is still explained. It is elevated. Yeah. You said that the anticipated spine is elevated. So what deformity we expect? Okay. Fixed reduction. So you have to make a special mention whether there is a fixed reduction deformity is there or is it there? You said there is no coronal plane deformity.
I'm sorry, no sagittal plane deformity.
So let us not confuse all those. So you can say that there is no fixed flexion deformity. So how did you make out that there is no fixed flexion deformity?
There is no exaggerated number.
What test did you do? Thomas hip knee flexion test. So can you just do? Sorry, let me just keep it. Doing the test again. Hold the mic. Yeah.
First, I place my hand.
Because now the people who are going to be there in knowledge this. Right, it's better that we go from the basics. Right.
I place my hand under the lumbar spine and I flex the opposite side.
You just explain to the patient. Right.
No, sir. I flex the opposite normal side itself and watch for the obliteration of the lumbar larynx. At that position, the affected side will be in a degree of flexion.
So how much you will flex? Sometimes you flex excessively, this limb may go up. So how will you find out if you are flexing too much?
Spine which is enough.
That is fine. Sir is asking any other way of finding out that you have flexed more. Because if you flex more, the pelvis can tilt. It can crush on your finger, but you still just want to put up with that, and then you are still flexing. How much degree to which you can flex, or what is that to find out that you have not overcorrected or tilted the pelvis?
So you have to see the ischial tuberosity. That's one. So if it's going to lift, so you're supposed to stop. It means you are over flexing the hip and your pelvis system. So that should not.
Can you just flex now? அடக்கி கால பிடிச்சுக்கோங்க கையால பிடிச்சுக்கோங்க. Right. Just see that. So இன்னும் கொஞ்சம் மடக்குங்க. Now he is trying to lift the pelvis up. Okay. So you should always keep your finger beneath the spine, not outside, beneath the spine. And as I was mentioning, you have to look for the கொஞ்சம் கீழே விட்டுருங்க லூசா. Right. So now this is the pelvis, which is in its plane. இன்னும் கொஞ்சம் மடக்குங்க. You see now, the pelvis is tilting up. The escape tuberosity is going up. This is what you have to observe. In addition to keeping your hand, right? And then the limb is lifted up. What will you do next?
Then I will try to.
Correct. You have to apply pressure. Find out whether the lordosis is reappearing. So these are the two things. One is obliterating the lordosis. See whether the escape tuberosity is not getting lifted up. Once the deformity becomes apparent, you have to again overcorrect. Try to push it down. See whether the lordosis is reappearing. And when it is not, it is about to reappear, you just stop it, and then you have to have a goniometer and time. And it should not be in this plane. That is very, very important. So if you are trying to say that it's not in fixed flexion deformity, it should not be as much as possible kept in this position. Because if there is an external rotation, there is a flexion deformity also, the limb might not get raised. It may go in this plane. Here it is not so. So you have to try to bring the limb to the neutral rotation as much as possible. And then, so you have to push it down. You have to make sure that the limb is in neutral rotation as much as possible. Okay. So here there is no fixed flexion, no sagittal plane deformity. Don't try to complicate. Right. So there is no sagittal plane deformity. If it is bilateral also, you get to skip, flex both lower limbs and bring it down to one by one. Okay. Right.
There is adduction deformity.
Right. How did you make?
But the Perkins method. First, I palpated the anterior iliac spine of both the sides. I found that side.
Audible there.
Yes, yes.
And the right side is found here at the level. Using my hand, the level of both the anterior superior iliac spine, I exaggerate the adduction and see when it gets squared, both the anterior superior iliac spine.
So this is not exaggerating the limb. Now you are trying to take the limb to adduction. Right. So what is the first movement that is taking place? So for example, this man is like this. The anterior spine on the right side appears at a higher level. You want to square the pelvis. You are taking the limb to the other side or adducting the limb. So there will be some more adduction which is left in this. So when you are trying to take the limb to the adduction, what is the first movement to take place? The pelvis coming up or the adduction deformity getting correct?
First, the pelvis comes.
So first is that whatever adduction which is possible in the right level, that will happen. I take the limb to the other side. So as she is taking the limb to the other side, the first movement that will take place is the available adduction in that lower leg. Right. Keep on adducting. Now what's happening? Now it is squared. Right. Both what just keep it there. Okay, both anticipally expand are at the same level. Right. So then what will you do now?
In get back to three. So the
How?
three range of
Okay. So now this is not the time to assess the free range of protection which is possible. Now we are trying to see when the anticipatory explain starts moving up. Till then you will come. Right. Has it started moving up? When is it? So it is almost neutral. Is there a fixed reduction deformity? So first you have kept it. You just see where is the position. Now I think it is squared. So when this antidisciplinary explained is at the same level, then the limb you just see. There may be a positional, the patient might tilt the pelvis this way or that way. And you suspect that, ask him to sit and then again lie down. All those positional things will get correct. If it is not so, if you think that this is at a higher level like this, then start taking the limb to the opposite side. Once you feel that both anti spine are at the same level, you just see this. So you can just keep your thumb like that or keep an inch here. Because it is this much away, it may be difficult for you to parallax error right now. You have to look from above. You have to see both anti spine are at the same level. Once you make sure that they are at the same level, then start taking the limb towards the neutral position. When it starts moving, so this is the time when you can just see. Once you think that it is at the same level, you do a movement like that. Now you see that the pelvis is moving and it is not the hip joint which is. Once you feel like that, you just keep it down and then see. I feel that still it is square. It is not going up. So it means that the limb is able to come up to neutral, but as I start affecting, there is no movement happening. The anticipatory expine moves. So you can say that though it looks positionally at anticipatory expine is at a higher level, when I square the pelvis, the limb comes up to neutral. So there is no fixed adduction deformity. Okay, right.
there is also a fixed external rotation.
So how you move? Yeah, just show.
Fixed and extension. By the log rolling, try to bring the neutral with petalas facing up. Facing the not able to bring.
So it is there is a fixed external rotation. So how much is the fixed external rotation?
Rather than like fixing the
No, an extension I just want.
pending.
So is there any better way? So which part are you seeing? When you see the foot, it looks like it is internal. So one mistake you should not make is that you should not look at the foot. So you should not look when you are doing a log rolling. So one way of doing a log rolling method is hold both wire limbs together at the level of the heel. By this, you make sure that the pelvis is not, because if you do that, the pelvis can tilt. You might assess the internal rotation more. So you just hold both heels together in full extension and then try to rotate. So don't look at the, if you look at the Right. So this is more. You have to remember. So the external rotation here was around 30 degrees. Here it was almost 45 degrees. You can see that. So this is the line and external rotation. Now you see internal rotation. So is it coming? Don't force. It is coming to neutral. We thought that there was a fixed external rotation deformity, but in extension it comes up to neutral. But external rotation is 45 degrees. You see the internal rotation in this way. Don't twist. You don't need to turn. So you are just turning the leg only. So this is external rotation. Internal rotation. So even here, so you have to make sure that it is not it's very tight, but still 30 degree of internal rotation and 30 degree of external rotation. Here 45 degree of external rotation, but 0 degree. It comes up to neutral. So there is no fixed external rotation deformity in extension. So this is the accurate way of finding out how much rotation is happening in extension. Don't just see it in with the patella. Right. Now tell normal side you see how much of inflection, how much external rotation, how much internal rotation. So this is
external rotation, sir. 45 degree. Loose ஆகுதுங்கப்பா. Loose ஆகுதுங்க. நானே பண்ணிக்கிறேன். நீங்க ஆட்டாதீங்க. விடுங்க. Loose ஆகுது.
So you have to look from above to see how much of rotation is happening, right?
Loose ஆகுதுங்கப்பா. நீங்க தலைக்கீழ படுத்துக்கோங்க.
தலைக்கீழ வெச்சுக்கோங்க. இங்க இருந்து. So this is the amount of internal rotation. One fallacy is that you should not abduct விட்டுறேன். So you should not abduct or adduct. So you should keep it in neutral rotation, neutral position, and then see. So you have to keep always your finger in the knee joint. Make sure that to what extent it is coming in that position, you have to keep it. So internal rotation is around 15 degree. When you take it outside, it is internal rotation. This you must remember. External rotation, if you see also, you try to maintain it. So this is around 30 to 35 degree. Okay. So here in this, you see.
Loose ஆகுதுங்க. கால் மடக்கி. கால் நீட்டிக்கும். இந்த முட்டி நீட்டிக்கும்.
லூசா வெச்சுக்கோங்க. அவங்க என்ன செய்றாங்களோ டாக்டர்
நானே பண்றேன். நீங்க கால் இது பண்ணாதீங்க.
Is it coming to internal rotation? So it is not coming to neutral rotation. Just it is coming up to neutral rotation. Okay.
External rotation coming to 45.
More than 45. Yes?
Yes, sir.
So the external rotation is exaggerated. Internal rotation is restricted in the right side. Right. How much of adduction abduction possible? We have checked only the fixed deformity. Right. How much adduction is possible?
Reduction up to 40 degrees, sir.
It is in neutral. Okay.
Oh, it's
45 degrees. It comes up to neutral. It doesn't go into abduction. The normal side?
The normal side it is. Abduction 25 degrees, sir.
Yes.
Abduction 30.
So abduction of 30 degree, adduction of 25 degree. But here the adduction is increased, 45 degree. But it comes up to neutral. Okay, right. Anything?
Measurements. Patient has an apparent shortening of right lower limb.
Flexion is same on both sides. Flexion you didn't
flexion 90 degree on right side, sir. 120 degree on left side, sir.
Okay.
Extension 20 degree on both sides, sir.
Equal. Okay.
Measurements, sir. Apparent lengthening, apparent shortening of 8 centimeter on the right side,
apparent shortening of
8
right side 8
centimeter.
centimeter and true shortening of 6 centimeters.
Now you want to maintain the same or you want to change? Previously, probably what you said was right. You had a fixed adduction deformity.
Yes, sir.
According to you.
Yes, sir.
Right. Now we want to change, or will there be any change, or it will
There will be change.
right? What is the change?
Because initially when I measured, I also kept the other limb in 20 degree of adduction and measured the true length.
You thought that the anterior superior spine was high and there was a fixed adduction deformity. Okay.
But now it is in neutral. Sir.
So apparent and true should be
Should be
same.
Yes.
So if there is no fixed coronal plane deformity, there will not be any change between the apparent limb discrepancy and true limb length discrepancy. Okay, right. So there is 8 centimeter shortening.
6 centimeters.
6
True length
centimeters.
is 6, yes, and supratrochanteric shortening by base of Bryan's triangle, it is 0, sir. Opposite side is 5 centimeters, sir. This side is 0, sir.
Okay, what happened to that 1 more centimeter? So you have to adjust this 1 centimeter. It is very, very difficult. You think that there is something problem in the infratrochanteric aspect also? Did you measure the segmental measurement?
Yes, sir. Femoral segment was 6 centimeters shorter, sir.
Do you square the pelvis when you see the Bryans? Of course, here
Yes,
it
sir.
is.
Yes, sir. You have to square.
Oh, not in this case,
Yes, sir.
deformity.
So you have to square the pelvis because Bryan's triangle is a true measurement. So you have to square the pelvis before you do.
Yes,
Right. So there was a supratrochanteric shortening of 5 centimeters. Segmental measurement from trochanter to the joint line, did you measure?
Yes, sir.
How much is it?
6 centimeters.
Okay, and that be 6 centimeters. No, from trochanter to the
No, sir. From trochanter to
the joint line, you didn't see.
No, sir.
You have to see.
Yes, sir.
So what does the supratrochanteric shortening mean?
Pathology in the neck or the
Trochanter, intertrochanteric region, trochanter or the neck or the neck shaft angle might have altered. So it has gone up. So what does the infratrochanteric, if it is only 5 centimeters, can there be an infratrochanteric shortening also?
No, sir.
Why?
It does.
Probably the pathology in the trochanteric and supratrochanteric also can extend beyond, no?
Yes.
So if you are not able to accommodate the entire shortening in the supratrochanteric region, you have to measure the segmental measurement. Where is the shortening? Because from anterior superior iliac spine to the median malleolus you have measured.
Yes.
There is 6 centimeters discrepancy.
Yes.
You have to account for that. You have accounted 5 centimeters in that. Then the pathology can be in the trochanter to the joint line or from the tibial segment. It can be in either. So where you have to find out. The segmental measurement is very, very important. Okay, right.
Yes. Then special tests, sir. Nelliton's line, greater trochanter lies above the Nelliton's line, sir. Superior to the Nelliton's line, and velocity to the anterior superior iliac spine, sir. And
Nelliton's line more important, significant.
supratrochanteric short.
No, there are other lines also. When is the Nelliton's line more significant? Which conditions? In a bilateral hip. Okay. So you don't need to compare it with the opposite hip. So just a unilateral side, you can say whether the trochanter is elevated or not. Okay.
Shoemaker's line, the line passes below and converges.
So where is the line? You should have drawn everything. Okay, right. In the exam, you should draw and show. Okay. Shoemaker's line converges below the umbilicus and the opposite side. Okay. Normally, it should be at the level or above the midline. Okay.
In Schwein's parallelogram, it is not parallel and converges on the right side. No. Trendelenburg sign could not be elicited, sir.
Why?
Because patient could not stand for more than 30 seconds and also gross shortening more than 5 centimeters.
Okay.
Telescopic test is positive. Sir.
Positive.
Yes.
Can you show?
Yeah, loose ஆகுதுங்க. Loose ஆகுதுங்க. கால் லூஸ் ஆகுது. நீங்க இருக்காதீங்க. ஐயா. நீ பாருங்க கால் லூஸ் ஆகுது. நீங்க எதுவும் பண்ணாதீங்க.
He is trying to extend. ஐயா நீங்க காலை நீட்டாதீங்க. காலை அவங்க டாக்டர் மடக்கி வச்சாங்கன்னா மடக்கிக்கோங்க. நீங்க டைட்டா பிடிக்கிறீங்க நீங்க. மூச்சு இழுத்து விடுங்க. ரைட். இந்த காலை மடக்கிக்கோங்க. ரைட்.
இது லூஸ் ஆகுதுங்கப்பா.
Able to elicit?
Yes, sir.
So how do you elicit? What is the method? How do you elicit?
Sir, placing my thumb in the anterior superior iliac spine and other fingers over the greater trochanter, the other hand holding the knee or the distal femur, flexion and adduction inline.
So if this is difficult, if it is patient is very obese, what you can do is ஐயா காலை லூஸா வச்சுக்கோங்க. நீட்டாதீங்க. நீட்டாதீங்க நீங்க. காலை நீட்டுறீங்க நீங்க. விட்டுருங்க. மடக்கிக்கலாம். இப்படி மடக்கி வச்சுக்கலாம். சரிங்களா? மூச்சு இழுத்து பிடிக்காதீங்க. ரிலாக்ஸ்டா இருங்க. So what you can do is allow the heel to touch the couch. So this is other way, but what you said is the right way of doing. But if you have difficulty in eliciting that obese person and you are not able to do it, so what you can do is this you can use it as a lever arm. Then you can keep the same other things are the same. So you can just hold the distal femur, hold the thumb with the anterior iliac spine and the other fingers in the trochanter, and then you can just do it like this. So this you don't require that much of effort. So you can see that I am able to lift and then I am able to push. So the trochanter coming and touching my finger is more significant than this coming up. Okay. I am not able to get that.
Holding it tight. Lose out.
Yeah, little yielding I can say. Yes, there is some little yielding. But this also you can do. This is one more method. Okay. If you are not able to get the telescope, right? Then
Examination of sacroiliac joint, opposite side hip and right side knee is normal, sir.
How do you do the sacred? How do you examine sacred action?
Sir, looking for tenderness in the sacroiliac joint in the prone position, sir.
You do favors?
No, sir. In hip pathology, we don't do favors.
Quite often people make mistake getting favors. Hip pathology, so it is going to be painful. So always local tenderness is very, very important.
Then distal pulses equally felt, sir. Yes. And then gait aided with walker support, sir. And, patient is not resting. Yes.
so is not able to bear weight on the right lower leg. Okay. You can't pass starting. Okay, right. Okay.
Superficial examination. Report. What condition is very?
Sir,
Some light is short.
Yeah.
protrusio acetabular.
இருக்கா இல்லையாடா? ஆமாமா வாஷ் பண்ண மட்டும் வரணும். சரி முடிச்சுட்டு வாஷ் பண்ணிக்கலாம் பார்த்தேன்.
Always you have to come out to the opposite, other joints,
Yes.
lymph nodes and vascularity. That's again very, very important. So that only completes your examination. You said you couldn't do a Trendelberg test. Which are the conditions where you don't do Trendelberg test? Okay. Your best advice.
And there is fixed adduction or abduction deformity.
So any coronal plane deformities, you don't do anything else?
Then when there is gross shortening of more than 5 centimeters, and patient is not able to stand for more than 30 seconds.
30 seconds, yeah, that's right. So when they are very young, around less than 5 years, where they can understand what you're trying to tell them, so again you can't do there. Some of the conditions where you can't do the Trendelberg test. So when is it positive, Trendelberg test? What conditions are, what is the problem actually?
So weakness of the abductor muscles on the affected side, sir. So when patient stands on the normal limb.
So only weakness or anything else? You have the lever arm, you have the fulcrum, you have the power arm. You told about the power arm.
Yes.
So any problem in this, all three, any problem in these structures can cause a positive tunnel burst. Okay. So in case you are not able to do, I mean, he cannot stand for that. So any other way to elicit that?
We can do it by standing opposite to the patient.
So it's called assisted tunnel burst. Okay, so that is very important. Okay. Okay.
Yes.
You have completed?
Yes,
so always opposite hip, other joints, neurovascular status, and the lymph nodes. Of course, you have spoken of the spine also, so that again is not. Okay.
Diagnosis.
So what is your diagnosis?
Sir. Sir, go ahead, sir.
Yeah.
So, diagnosis is anatomical diagnosis, coxa vara.
Why do you want to say coxa vara?
Because patient has an exaggerated adduction and external rotation, and first there is apparent shortening, and there is exaggerated adduction and external rotation, and no abduction and internal rotation possible, sir.
You said the telescopy is positive.
Yes, sir.
Telescopy is positive. Can it be coxa vara? So it becomes an unstable hip. So you have two conditions. One is stable conditions and another unstable hip. So when you tell telescopy is positive, we assume that there is some non-union or something like that, or something hip is not in position.
Yes,
Okay, so it becomes an unstable situation. Your stable situation is coxa vara. So do you have points for coxa vara? Only a couple of points you have, but this one thing, telescopy being positive, is going against your diagnosis of coxa vara.
So it overtakes all the other things. So if I would say that this is probably you're seeing the X-ray, that's the reason why you are putting it as coxa vara and telescopy. Either one is wrong. So I would say here I am not able to elicit a classical telescopy. With difficulty, I am imagining that there is some evening which is present. So in this case, when everything else, so when it is unstable hip, when the telescopy is positive, then you don't have any other diagnosis. Everything else goes to the back seat when there is a telescopy positive. So what are the characteristics when there is an instability, when there is instability?
So all range of movements will be exaggerated.
Exaggerated one. Do we have exaggerated range of movement?
Only external rotation and adduction is exaggerated, sir.
Exaggerated. Is it exaggeration of arc of motion, or is it the joint motion itself that is exaggerated? Do you know the difference? You don't know. So the arc of motion is if the patient has abduction of 45 degree, adduction of 30 degree, the arc of motion is 75 degree, the entire arc. So it can be 60 degree of adduction and it can be 10 degree or 0 degree of abduction. Means that the articular surface is changed its location. The arc remains the same, it is not restricted, but it is only the range of movement differs. Instead of abduction, it is going exaggerated adduction. That is one. Whatever you said, there is an external rotation of 45 degree here, and there is no internal rotation. So the entire arc of motion is 45, which is changed. In the opposite side, there was around 30 degree of external rotation, 15 degree of internal rotation. So that was also 45. The adduction was around 45 degree here, you said. In this side, there was adduction of around 15 degree and abduction of 30 degree. So the arc of motion changed, but the range of motion did not change. If there is an unstable hip, the range of movement itself should be exaggerated. 45 degree of abduction, 45 degree of adduction, external rotation of 45, internal rotation of 45. That means that the range of motion is. So here, what do you think it is?
The range of motion has not increased, sir.
It is only the arc of motion that changed. Okay. So any other point to say that it is unstable? Of course, what are the points to say that it is unstable?
one is telescoping, the range of motion remains the same, then anything else. Right. So let us forget about the telescoping because it is equivocal. When I found it was only suspicious yielding. So if you think that the telescopy is negative, now what will be your diagnosis?
Coxa.
Why do you say Coxa? We'll just ignore as of now. Is it a classical telescopy?
No,
The diagnosis can be entirely different, radiological. We are not bothered about it at all. We are bothered only.
No, sir, not a classical.
No. Tell what are the features of Coxa in this.
So there is apparent shortening of the
Is it a true shortening or apparent?
True shortening.
Then why do you want to say it? Because you have completed your examination.
Yes, sir.
You have to tell the final findings, right?
True shortening of the affected limb. True shortening of
So true supratrochanteric shortening. Measurement comes late, but anyway, okay. Then what are the other points?
So then in moments
When the trochanter.
proximal migration of the trochanter on the affected side, sir. Thickened and irregular, non-tender. No. External rotation and adduction movements were exaggerated. Sir.
So the classical findings of Coxa are there will be exaggeration of adduction and external rotation, restriction of abduction and internal rotation, true supratrochanteric shortening with Trendelenburg sign positive. So these are the classical signs of Coxa, of which only the Trendelenburg sign you could not elicit. Apart from that, all the classical features of Coxa are there. Okay, right. So if there is a telescopy which you are very sure, what is your pathological diagnosis? If telescopy you are not very sure, what is your pathological diagnosis? This is about the anatomical diagnosis, right?
Pathological telescopy positive could be a non-union of the neck of femur, sir, or trochanteric.
Neck of femur doesn't come. You can't say. Is it not?
Usually the trochanteric non-union is very, very rare. So even if you test it as neck of fracture non-union, your trochanter is thickened, irregular, all that doesn't happen in the neck of femur. Usually the trochanter happens, trochanteric problem, not great trochanteric problem. Usually rarely that's how the fracture neck of femur.
So, trochanter thickened, and what are the points for trochanteric fracture is the shortening. Neck of femur, the shortening doesn't happen this much. Acceleration, of course, it can happen this much. So, for you to say as trochanteric fracture, it is malunited.
Pathological.
It is Coxa.
Yes, sir.
If it is unstable,
Non-union.
non-union of trochanter. Correct? The non-union of trochanter, does it happen regularly? Why? So usually it goes for a non-union. Extracapsular. So it malunites. So if it goes for non-union, it is only most likely to follow. So what are the history following trauma?
So following trauma, patient had head injury and hip fracture, sir. So patient was in treatment with ventilator for 1 month, sir. After which patient went to hospital and was in pin traction for 2-3 weeks, sir. Then patient didn't tolerate. Then he started on assisted weight bearing. Yes,
Okay. So following distraction or following surgery can happen. Very, very rare that conservatively managed to go in for a non-union. So what fractures of trochanter can go in for a non-union?
So you
cervicotrochanteric junction.
right, correct, basal. So it can behave like an extracapsular fracture. It can behave like an intracapsular fracture. So that is the classical description. Okay. So now we are left with. So of these two, what you are more inclined to?
Malunion of intertrochanteric trochanteric fracture.
So you are not very much convinced about the telescope. And suits everything. So in the exam we are presenting, you have to be convinced about one thing and then say. So some might give you some tips. You are not able to justify that. Then it is very, very difficult. Examiner will form an idea that you have seen the X-ray, got the tip, and will not be appreciating it at all. Okay. Right. So what are the points against malunited trochanter?
The patient not walking for 14 months. So many malunions you see. Patients with limp with Karsavara, they will be able to walk. Here only the patient is not able to walk for 1.5 years. After 14 months, the patient is still not able to walk. These are the two things. Anything? Okay. So what shall we do?
Sir, X-ray of pelvis with bilateral hip AP.
Can we go in for the X-ray?
Sir, can I? Who wants to use?
Yeah, please. Share போட்டுட்டு
Wait, but I'm two. Sugudev sir, walker key எடுத்துட்டீங்கன்னா நல்லது walker.
இல்லைன்னா இந்த இதை ஜூம் பண்ணி இது அத இந்த இதை அந்த எக்ஸ்ரே வருதா இது அந்த இதை நல்லா ஜூம் பண்ணுங்க அந்த எக்ஸ்ரே நீ தனியா எடுத்துட்டு வந்து பண்ணிடுறீங்களா
இந்த ஜூம் பண்ணியாச்சு
வந்து என்டையர் ஸ்கிரீன் எஸ் இப்ப ஜூம்ல உங்க இதுல தெரியுதா ஜூம்ல என்டையர் ஸ்கிரீன் போட்டுரு ஷேர் ஸ்கிரீன் என்டையர் ஸ்கிரீன் அலோ ஷேர் ஸ்கிரீன் விண்டோ இல்லப்பா அலோ ஷேர் ஸ்கிரீன் பசங்களுக்கு தெரியல இப்ப உன்னோட இதுக்கு போ எக்ஸ்ரேக்கு இப்ப ஷேர்ல தான்ப்பா இருக்கு என்டையர் ஸ்கிரீன் போயிரு ஸ்கிரீன் ஷேரிங் நீ எக்ஸ்ரே போ நீ ரமேஷ் வேற கன்ஃபியூஸ் பண்ணிட்டு இருக்கலாம் வந்துருச்சா ஸ்கிரீன் ஷேர் ஜூம்ல என்ன தெரியுது சரி ஜூம்ல போயிட்டு திரும்பி நீ இதை நல்லா இல்லன்னா இது பண்ணுங்க அது பண்ணுங்க நீ உன்னோடதுல போயிட்டு நீ ஷேர் ஸ்கிரீன்ல நீ கொடுத்தியா கொடுக்கலையானே தெரியல எனக்கு. ஷேர் ஸ்கிரீன் கொடு. அலோ ஷேர் ஸ்கிரீன். இப்போ சார் மேல பாரு, ரைட் கார்னர் இன்டென்ட் ஸ்கிரீன். கரெக்ட், யுவர் ஸ்கிரீன் ஷேரிங். இப்போ இப்போ ஸ்லைட் ஷோ. இப்போ தெரியுதா? ரைட் ரைட். நவ யூ ரீட் தி எக்ஸ்ரே.
So, plain X-ray of a skeletally mature individual showing the pelvis with bilateral hip anteroposterior view. Patient has a fracture of the intertrochanteric region, which is a non-union. The ends are rounded and sclerosed with the proximal migration of the greater trochanter and with secondary arthritic changes.
My God, now only the problem comes. How do you see secondary arthritic changes?
Sir.
How the joint is? Is the joint is narrow? Is there osteophyte there? Or is it not there?
So,
There is the viability of the head also. Is the head viable or not viable?
இதுல சாமிச்சா அதுக்கு தெரியும்.
So in case of
இதுக்கே தெரியாது.
you see sclerosis on it. So in case of fracture like there is neurotic changes. So what is the this is a vascular.
Where is the fracture? It is a trochanteric fracture, something like a basal intertrochanteric fracture. Has it united or not? The fracture line is seen and the ends are sclerosed. So how is the neck shaft angle? It is decreased. Gross coxa vara is seen. So when you come to the joint, so the evidences of osteoarthritis are: one is sclerosis. Is there any sclerosis in the acetabular articular surface? Secondary osteoarthritis? No. Second is osteophytes. Is there any osteophyte you are able to see? Medial osteophyte, lateral osteophyte. The end is very, very smooth and rounded. No sorsal, no sclerosis, no osteophyte. Third is narrowing of the joint space. You see the medial joint space, you see the lateral joint space. Both are intact. Okay, so no evidence of osteoarthritis. Fourth is, in the case where there is a non-union, for the osteoarthritis to develop, there should be incongruity and there should be weight transmission. These are the two prerequisites for an osteoarthritis to develop. Here neither it is incongruous. Why it is not? Whether it is vascular or non-vascular, here it is vascular, as I was mentioning, because the density is maintained, not sclerotic. Even if it is avascular, unless weight transmission takes place, it is not going to collapse. There is already a break in the fracture in the trochanteric region. So weight transmission will not go through the head. So when the weight transmission doesn't take place, even if it is avascular, it is not going to collapse. When the collapse doesn't take place, then there is no incongruity. The weight bearing doesn't take place. So there is no incongruity and osteoarthritis development. So in a non-union neck of femur or trochanter, the hip joint never goes in for an osteoarthritis. Never. Okay? Right. So it is a trochanteric fracture, non-union. Right. What do you want to do?
Valgus osteotomy, valgus trochanteric osteotomy, and
So, right. So,
What are the problems? One is
non-union.
secondly,
If you enumerate the problems and you can plan your treatment, that's always you have to be there. The exam comes at this stage, you have to say this. These are other problems. So now, tell what are the problems patient is saying now?
Sir, non-union of
this non-union.
trochanteric fracture, then limb discrepancy of 6 centimeter, and decrease in neck shaft and coxa vara deformity.
Is it salvageable?
Yes, sir, because head is viable,
Yeah.
you can salvage that.
Because
First, our aim is osteosynthesis and salvaging the femoral head, relating the fracture. That is the first step Sir has mentioned. So once that step is defined, so how are you going to achieve? Second, as you said that it is proximally migrated, it has to come down. Third is, what is the fracture plane? Fourth is, you have to decide on what osteosynthesis you are going to do to get it unite. Now you tell one by one. So now you have decided, you have told about saving the femoral head. You are not going to throw it off and do a replacement. Second is, there is a neck shaft angle decreased and proximal migration. Third is assessment of the fracture line. Fourth is the osteosynthesis. So you will first try to assess how much it is yielding, because it was not, even the telescopy was not coming. So whether you have to do a traction X-ray, any traction X-ray is there?
Yes, sir.
So this is the traction X-ray. So now you see that very little movement is happening. So this is the reason why we are not able to elicit a gross telescopy. A very little movement is happening and it is coming up to this much. So next thing you want to take.
CT of the
What
CT.
Ah.
is also done. Okay.
Plus is the non-union.
It will confirm, already it is, see, it will further confirm, and you will know how much of the neck profile and other thing, and the amount of comminution is all the profile of the proximal trochanteric region you will assess. That will help you to plan your osteosynthesis treatment, whether you can go for an extramedullary or intramedullary fixation. Okay. Okay. That you have done. Is it done or not? This case.
No, sir.
So now you got that. So what is the next step? Since there is some yielding, you want to put the patient on traction?
Yes, sir.
You can put the patient on traction. If there is no yielding, no point. There is some yielding, so we can stretch it a little bit further. What traction you want?
Upper tibial skeletal traction.
Skeletal traction, definitely no skin traction. So skeletal traction, if you are doing, you have to give really good traction. So what traction? You want to increase the weight.
Distal femoral.
Distal femoral, you can afford to put more weight and give traction. So you can put in a distal femoral traction. Some can do, some need not do. Right. That is the second aspect. Putting in traction and trying to bring it down. Third will be to go inside and then fix it. So that is when it comes. So don't be in a hurry to say about validation. So you have to really release all the non-union fibrous tissue and soft tissue. Get the neck. It is not only the trochanter coming down. It is the head and neck to rotate. So you may have to do some arthrolysis in the joint. Any metaphyseal non-union movement happens only at the non-union site. It doesn't happen at the joint. So if the joint doesn't move for 14 months, everywhere it will be totally fibrosed. Arthropibrosis will be there. So you have to do an arthrolysis. So open the capsule, release the femoral head out and make it moving. Then you bring it down. So once you bring this down and release the proximal femur and try to bring it down, you will gain the length and you will gain the angulation. So if the angulation you feel, that is more vertical, because it doesn't depend on the distal fragment fracture state angulation. It depends on the proximal fragment, how much, because there will be resorption and rounding off of the trochanter. If required, you may do an osteotomy. If it is not required and you have got a good apposition and a transverse orientation of the fracture, then you can go in for a fixation. So what fixation you would like to do? So you must have
Dynamic hip screw. Shear force should be converted to compressive
so
forces.
that is what you will do it by achieving by doing ortholysis. Rotating the femoral head and bringing it more transverse. But which is do an ortholysis and bring the head and neck, it will become transverse. Once that becomes transverse, you can put. But in dynamic hip screw, if you want to put and if you want to make it really wellness, you have to increase the barrel plate angle. Normal 135 what we normally use, you have to have 140, 145. So that it will be really having a vertical orientation and get more impact. Okay?
So I'll bone grafting. So in addition to whatever you do, you can put some bone graft so that it will be.
So always better to keep other options. Suppose you are not able to achieve your osteosynthesis, your next option also is plan and keep it as a standby. What is the next option?
Age and all this.
Prosthesis, bipolar hernia.
Bipolar.
So what is the age?
59, sir.
One thing is like when these patients don't bear weight for a long time, the acetabular cartilage and the cartilage of the bone can come down because the nourishment of the acetabular cartilage comes from the synovial fluid which is in the joint. So if there's no movement, no nourishment is going to happen. When you see these open and see, the cartilage is like a flake. So you're doing a bipolar hemiarthroplasty again, your acetabulum should be good because the movement is going to be between the implant and the acetabulum and the head and the so that is so if your acetabulum cartilage is not good, like it's going to happen in this case, so we have to go for a total arthroplasty. So he's only 54 or something you said, but that is a good option. So that is always a good option. Then a bipolar hemiarthroplasty.
Bipolar, a fracture beyond 3 months. Most important is the cancellation of the dense cancellous bone here. The entire sclerotic, so you see the sclerotic rim of the acetabulum here. So how sclerotic it is? A well-defined line and a well-defined trabeculae on the normal. If you see here, it is almost cancelled. There is no clear-cut demarcation between the cancellous bone and the subchondral bone in the acetabulum on the affected side, right side. If that is the case, if you do, the problem is that it can very easily erode and go in for a protrusion. So this is the case. You can have it as a, it is not in the literature, but you can have it like if it is beyond 3 months, it is always better to do whatever be the age, even if it is 80. If it is beyond 3 months old fracture, then it is better to do a protrusion. Otherwise, this will go in for an early osteoarthritis and protrusion. Okay?
Yes.
So what type of stem you will use? Like, so you want to use a primary stem, you want to use a long stem, distally fitting stem or possibly holding stem. So what type of stem you use?
Distally fitting.
If you can answer this, that's okay. I think you can probably, it's finally a distally fitting stem. Because your primary fitting stem requires a metaphysis, but again here the metaphysis is completely resorbed or damaged, so it is not possible. So you can use a distally fitting stem. So what bearing surface is what you want to prefer? So what is the best bearing surface you want to give to your patient?
So you want to reduce the wear. So the wear is less with the bearing, different bearing options are, it can be a cobalt chromium on polyethylene. It can be ceramic on polyethylene. It can be a ceramic against ceramic. The other option which was mentioned there was metal on metal. But due to so many reasons, a lot of products went into distribution, so that we will not take it. So cobalt chromium against poly, ceramic against poly, or ceramic against ceramic. They are second years. So if you want to reduce the wear, theoretically it is ceramic against ceramic is the best bearing option where it has the least wear particle which produces the aseptic loosening or osteolysis. But in the registry, it is well proved that so far
the ceramic on polyethylene does well, and it is less forgiving, I mean more forgiving than ceramic against ceramic, which has the other complications like squeaking and other problems. So these are the tribology you must know of. What are the bearing surfaces? Why should you use different bearing surfaces? What are the advantages and disadvantages? And what is the registry data? So all these factors you have to assess before you tell what you want to do. Okay, that is what sir wants to know. So if you want to do a total hip, the proximal fit, the metaphysis, you see here, this is the area of bone where it is very, very important for the bone to integrate. So if this part is not there, it is spastic femur. If you use a proximal fitting stem where it be very, very less cancellous bone here, you will have trouble. So a distal fitting stem you have to use, and it should be a total hip and it must never be a bipolar. Okay, right. Any other questions in chat box? If they put at the end, we can answer. Okay, very well presented. Well done.
Good case for discussion. Very good case. Very rarely you see regarding one. Yeah. Usually basal. Most of them do basal.
Okay, right. One day I was watching the Amazon. You know, let us watch. Yes.
So, it's case of 20-year female, Miss Tuvarsi, residing at Nindivanam, agricultural field worker by occupation, came to hospital with chief complaints of pain in the right thigh for the past 3 months and swelling in the right thigh for the past 1 month. Patient was apparently normal 3 months back. Then she developed pain in the right thigh, which was insidious and urgent, progressive in nature to attain the present severity, and a dull aching type of pain, which is aggravated on activity and relieved on taking pain medications. There is a pain which is associated with limping for the past 1 month. The patient developed pain followed by swelling for the past 1 month, which was insidious in onset, progressive in nature. There is no
swelling developed only after
yes,
for the past 1 month.
Then which is aggravated on there is no aggravation and relieving for swelling. Then the patient the swelling is not associated with tingling.
So for swelling, you don't say aggravating factor, relieving factor. Swelling, you have to say whether progressively increasing or it is static since the time of appearance.
Then the swelling is not associated with tingling, numbness, and
Swelling increasing and decreasing in size. What do you interfere? Suppose the swelling is increasing in size, they will be taking some pain medication and all. So that will go in more in favor of an inflammatory. Okay.
Inflammatory swelling.
Or infection related also.
Okay. The swelling is not associated with tingling, numbness, weakness, or any distal edema. There is a there is no history of fever, loss of weight, and loss of appetite. There is a history of difficulty in activity of daily living like squatting and sitting cross-legged. There is no history of any bowel and bladder disturbances. The patient had a history of medication taken from a nearby hospital for the pain for the past 3 months, which is the pain subsides for the period of 1 month, 1 week, then the pain again develops. Then the patient went to a nearby GH from where the X-ray was taken. They found it to be a swelling which arises from the bone, and they referred to our hospital for the further management.
Maybe night pain.
Yes, sir. There is a pain, sleep disturbance in sleep, and a night pain is there.
It is most important
Yes.
to tell the severity, what are the aggravating relieving factors, how much it is relieved, and then it is also very, very important.
There is a history of disturbance in sleep, and there is a night pain is present. There is no history of similar complaints in the family members. There is no history of trauma, sir. There is no history of previous hospitalization, and there is no history of surgery in the past. After admission, the patient had a needle biopsy 4 days back.
Those things and all, yeah, tell.
After admission, patient had a image guided biopsy, and 2 weeks back, then which came to be inconclusive, and the patient.
Don't say everything. Okay, so this is a clinical examination, right? So needle biopsy and so you saw all those findings, is it? All those records. So don't say all those things, right? So what you can say is, after the admission, patient was undergone procedure under the imaging, if the patient is able to understand, putting in a needle into the swelling. That is how you should say. So did the patient say as biopsy? So all those technical terms should not come. And you must not say everything like that. The patient might tell the diagnosis. So your purpose here in the examination is only to arrive at a diagnosis from the history and the examination what you found. Okay, right.
Maybe any similar swellings elsewhere in the body? Any similar swellings elsewhere in the body?
No history of similar swelling elsewhere in the body.
Okay.
With this brief history, I examined the patient after getting concerned.
No, what is your, with the history, what are your suspicion or what are your probabilities?
With the history, I came to know there is a swelling in the distal tail, which is maybe arising from the bone.
No, that the patient has herself. So all those things don't say. Patient, the X-ray they have taken and they say that the swelling is arising from the bone. You said those are all things which you have to confirm it from your examination, whatever the patient says. Okay, so the patient went to a local hospital from where they have referred the patient to our institution for further management. That is how we should end it. Right. From the history, what are your probable diagnosis or suspicions?
The swelling may be benign or malignant swelling, sir.
So why do you want to think straight away into benign or malignant swelling? What are the suspicions? So when you are asked, you have to say whether is it congenital, infective, inflammatory, traumatic, neoplastic, or metabolic, or any other miscellaneous condition which you want to rule out. So in this, what are the things you can think?
Maybe infective, neoplastic.
So these are the two suspicions: an infective condition or a neoplastic condition. Okay. So how why do you think in terms of neoplasm?
The patient developed a pain which is followed by swelling, sir. Then the swelling which is progressively aggression of the swelling, which is for the duration of the past 3 months, the swelling is.
No, you said the swelling, the pain is there for 3 months.
Yes, sir.
Swelling for the past 1 month. Is it 1 month or 3 months swelling?
1 month, sir.
Then why do you want to change it to 3 months again?
Pain for 3 months and swelling for 1 month, sir.
Hmm.
The swelling is more aggressive, so the chance of.
No, you don't know. You have not seen the patient. You have not seen the swelling. So according,
Since. Yes.
you are telling now you are only in the history. I am asking you from the history, what is your diagnosis? So from the history, what you can say is a pain which is progressively increasing and which is disturbing the sleep, even present at night at rest. And the swelling appeared 2 months later for the past 1 month. which is also progressively increasing. And within 1 month, it has rapidly increased in size. So these are the things which make me think that it might be a neoplastic origin. Understand? You cannot say a patient has told, hospital has told, and that is the diagnosis. So then the entire examination is over. In clinical examination, they will not ask like a long case. Here, all aspects we want to cover. That is the reason why we are going into detail. Understand? So this is not the way the short case, because this will come as short case and you will not be allowed to present like this in detail. Okay? Right.
With the history,
Why do you think in terms of also infection?
the swelling which is
Again, progressively increasing
increasing.
swelling and painful swelling. You cannot rule out. Okay.
Based on the history, the provisional diagnosis came to be as infective or a neoplastic injury.
Okay.
With this history, I examined the patient after getting a consent with a female attendant standby and a patient in lying position. On examination, local examination with
No, general examination you have to say.
on examination, patient is conscious oriented, already built
No,
on
all
life,
those things you need not say. General few things only. Yeah.
not prior, not quick, not sinuses and no clubbing, and head to the examination is normal, and systemic examination was found to be normal, and on local examination with adequate exposure, patient is examined in lying position, examination of right lower limb with attitude, hip in flexion and hip is flexed and externally rotated, knee in mild flexion and ankle at position of ease and patella facing outwards. And on inspection, swelling, diffused circumferential swelling present over the distal thigh, which extends from the middle third distal thigh junction of thigh to the knee joint on the anterior aspect, and on the posterior aspect, swelling which extends from the middle third distal junction of the thigh and to the just proximal to the popliteal piece. There is a sutured wound of approximately 0.5 centimeter, which is present over the anterior aspect of the distal thigh. Suture wound of 0.5 centimeter, which is present over the anterior aspect of the distal thigh. With there is an engaged veins present over the lateral aspect of the thigh. There is no sinus, no discharge, sinus with discharge, no.
Yeah. Okay. So there is an engorged vein over the lateral aspect of the thigh. Okay. Apart from that, anything else?
The skin or the swelling is stretched and shiny, sir.
Right. So that is more important. So what does it indicate?
Aggressive tumor with compromise of vascular venous condition.
Right.
Yes.
The engorged veins you have told. You said that skin is stretched and shiny. What does it tell you? What does it indicate?
Infiltration of.
Infiltration of the skin. If skin is stretched and shiny, you will think it is infiltration of the skin. It is the aggressive means what? It is the rapidity in which it has increased in size. If the swelling is rapidly increasing, the skin doesn't have time to accommodate. So it gets stretched. So if the skin is stretched, it becomes shiny. The normal rugosity is lost. Okay. So if it is stretched and shiny, it means that the rapidly increasing swelling. Okay. Then.
And on palpation.
So you think that the knee joint is involved or not?
Yes.
Why do you say that knee joint is involved? It is in the lower thigh. I say that it is a knee joint effusion or a synovial swelling which is coming up to the lower thigh. Why do you say knee joint is not involved? So before you say no, you have to tell something.
It is the patient.
Yes. Yes. To say that it is the knee joint, you say as dogmatic that you are very clear that knee joint is not required. How do you know it is not required?
With history, the patient able to, with an examination, the
No, an inspection. Now we are in inspection. So I have to say that when the knee joint swelling is there, what is the area mainly it will involve? Suprapatellar and then suprapatellar and then apart from that, why suprapatellar is involved?
medial
Medial
joint.
joint illa
Medial parapatellar.
the parapatellar, infrapatellar on either side of the tendon. So these are the areas in which the swelling will be obvious. So the infrapatellar region is normal. On either side of the patellar tendon is normal. Just up to the lower pole of the patella it is normal. The swelling just extends. So it is unlikely that it is a swelling arising from the knee joint which is going up primarily. Okay, right, next.
And palpation, sir. Superficial palpation, there is a warmth present over the swelling which is compared with the normal swelling. Then on there is a pointed tenderness present swelling, sir. And on deep palpation?
No, first if you are starting to palpate, you have to tell us the extent of the tumor, from where to where it is extending, and the anterior aspect, lateral aspect, medial aspect, posterior aspect, and what is the surface, and all those things only you have to tell. Now, straight away don't go in for tenderness. Consistency, what is the plane of the swelling?
The swelling is present of size 16 plus 10 plus 10 centimeter, present over the distal thigh with irregular surface with ill-defined border. The superior border of the swelling on anterior aspect which extends 22 centimeter from the medial joint line and 6 centimeter from the inferior border of the swelling which extends 6 centimeter from the medial joint line. And on the posterior aspect, the swelling
inferior to the joint line.
Inferior bar of the swelling which extends from inferior bar of the swelling extends 6 centimeter from the medial joint lines.
Above or below, proximal, I don't understand. Superior border is 26 centimeters.
22 centimeters.
Inferior border is
6 centimeter from the medial joint lines.
6 centimeters above the
yes.
Above sollu.
Yes.
Okay.
Then on the posterior aspect, the swelling extends 18 centimeter from the popliteal piece and 2 centimeter from the superior bar of the swelling extends 18 centimeter from the popliteal piece and 2 centimeter above the popliteal piece inferior bar.
Okay.
Medially and laterally the swelling continues. Yes, sir. Plane on contracting the muscle, the swelling not reduced in size, which means it may suggest that the swelling may involve a soft muscle comfort.
So what muscle you contracted and what muscle?
Sir, quadriceps muscle. I'm asking the patient to contract extend the knee, sir, and feel for swelling, reducibility of the swelling.
Reducibility of the swelling?
Prominence of the, not reduced on contracting the muscles.
No, contracting the muscles, your swelling is more prominent or less prominent.
Remains the same. It's the same.
That doesn't mean there is no involvement of the muscles. Maybe either the muscle.
Yes.
So he says that it is involving the muscle also, that is the reason why it remains the same.
If the muscle is swelling between the muscle, it reduces, right? Or above the muscle, there's a variation.
If the swelling beneath the muscle, if the swelling is beneath the muscle, the swelling reduces in size.
But here you think that it is not reducing in size. Okay.
Skin of the swelling is pinchable?
Yes, the skin of the swelling is pinchable.
So all those things you have to tell on your own. Okay, skin is pinchable and contracting the muscle, the size doesn't change. Then
Yes, sir. Consistency of the swelling is variable, sir. Variable in consistency with ill-defined borders.
no, variable it doesn't mean anything. So from soft to hard, cystic to soft, hard to So that you have to say.
Firm to hard inconsistent.
Firm to hard inconsistent, which is predominantly firm and some places it is hard.
So,
Or it is predominantly hard and it is firm some places.
so predominantly there is a hard inconsistency, sir. Somewhere it is firm.
So that you have to say. So with that only we will be able to understand the characteristic of the swelling. Okay. So where is it soft?
So,
No. Center or margin, where is it soft? So where is the swelling from?
From there is.
Where is the swelling arising from? You can make it simple. You don't need to say that it is like undergraduate, contracting the muscle and everything. So is it arising from the bone, femur? So you can straight away say it as femur. It is arising from femur. Why do you say it is arising from femur? It is the swelling is continuous with femur. I am able to palpate on the medial and lateral side. Lateral it is difficult. On the medial side, you will be able to palpate between the because lateral side IT band is there. Medial side, you will be able to see that it is continuous. Okay, it is, and it is immobile. It doesn't move on side to side or superior inferior. It doesn't move. So it is arising from the bone. If that is the case, everywhere it should be bony hardened consistency. Where is the softness?
In the center.
In the center. So what does it indicate? Okay, we'll come to it later. Then.
And movements, sir.
So there are other things which you have to say.
There is no reducibility, compressibility, and transformation test is negative, sir. And
so transformation test you have to tell.
So that's the reason why we say, do you have an illuminoscope? Do you have a torch? Super, very good. So all those things comes only undergraduate level, it is okay. Okay, right. Then examining hydrocele and seeing transformation, that's all fine. Now we are examining, right? Then
movements, sir.
No, the popliteal region it is extending. Is it not? I am interested in certain structures.
It's not extending up to the top. It should be more proximal.
Just proximal, right? So
no involvement of popliteal.
No, are you able to feel the popliteal vessel?
Yes, I examined the distal pulse, sir.
No, distal pulse is different.
Popliteal is a vessel I examined. It's quite felt.
Is it more or is it encased? Are you able to palpate the tumor?
Compared with obviously is equally felt.
Equally felt.
Yes.
At the level of the tumor.
Yes, popliteal pulse.
At the level of the tumor or just distal to the tumor, distal to the swelling, you are able to feel the popliteal.
Distal to the swelling, I examined by compared with opposites.
Okay, so proximal to that, are you able to palpate the vessel? Not able to see. Okay, in the over the swelling, you are not able to see the palpate the popliteal vessel. So what does it indicate? You say that it is arising from the bone. You are feeling that posteriorly the swelling, but you are not able to feel the popliteal vessel at the level of the swelling. So what does it indicate? Tumor might have
invaded the vessel.
Invaded is a bigger term. It might have encased. So you are not able to feel the vessel. Okay. If it is some other swelling, if it is an exostosis on the posterior aspect of the femur, how will the popliteal vessel be? Usually it will be more bounding and easily palpable. It is just pushing. Here it is not pushing the vessel, it is just going round the vessel. You would understand that? Okay, then.
Movements.
No, you have not told about the joint line. Did you see about the medial joint line, lateral joint lines? Because based on that only you can say whether it is which part of the bone the swelling is arising from. Where is it arising from?
Metaphyseal, like epiphyseal, metaphyseal.
Is epiphysis involved? Is metaphysis involved?
Metaphysis.
Epiphysis is not involved. So how do you know that?
From the joint line.
So did you feel the joint line? Are you able to feel the joint line separately?
Yes.
Hmm?
Yes.
Medial joint line, lateral joint line. That is a very, very important point for you to say. To say that it is not involving the epiphysis. If it is involving the epiphysis, then you will not be able to feel. It will be the tumor which is coming up to the joint line. I am able to feel only the tibial, proximal tibial margin. I am not able to feel the distal femoral. The joint line I am not able to feel. It means that the swelling is arising from the near the joint or the epiphysis. Here you are able to feel the joint line clearly, medial and lateral. Okay, then. Movement.
Movements of adjacent joints. Range of movement at the knee and bilateral side. There is a extension lag is present on the right side, sir.
What do you mean by extension lag?
The patient able to do active flexion up to patient able to do extension of up to
What is the normal range of flexion?
sir 0 to 130 degrees, sir. For this patient not able to do active extension, sir.
Passively you are able to do?
Yes, sir. Passively full range of movement is possible.
Very good. So passively full range of movement, full extension is possible. Yes. Actively the terminal 10 degree of extension is not possible. Yes. Okay. How much? Then terminal 15 degree.
30
to 50 degree. Just asked to do XLR, ma? Active XLR. Eba, ida paru. Not able to do. Commissioning, no? XLR.
Yes, sir.
Active XLR. Active, நீங்க இல்ல. தூக்குமா கால அப்படியே தூக்கு. Don't support. You don't support. Ask her to extend. அம்மா காலை எவ்வளவு தூக்க முடியுமோ தூக்கு. நீட்டின மாதிரி அப்படியே தூக்குமா, மடக்காம எவ்வளவு முடியும்? கொஞ்சம் கூட முடியலையா? எதிர்த்து உட்காந்துட்டு தூக்குமா? இல்லைன்னா உட்காந்து காலை நீட்டிக்கோ, கீழே தொங்க போட்டுக்கோ, காலை தொங்க போட்டுக்கோமா. அது இதெல்லாம் கீழே இறக்கி விட்டுருமா, அதை கீழே இறக்கி விட்டுரு ட்ரெஸ். காலை நீட்டுமா, இதை
இந்த கால்
சப்போர்ட் பண்ணாம நீட் எவ்வளவு நீட்ட வருது? வெரி குட். So this is what you should say. போதும், அந்த காலம் நீட்டுமா. So this is full extension. The terminal 20 degree of extension she is not able to actively. So this is the extensor line. Very good. Right. காலை உட்காந்துக்கோ. Next போதும். இல்ல சும்மா காலை தொங்க போட்டு உட்காந்து. Why should I want to make her uncomfortable? That's enough. You have examined her, no? Yes. Right. What else you want to see?
On measurement, there is a calf muscle and calf muscle. There is no calf muscle wasting, sir. Comparing with the opposite side, there is a thigh muscle wasting of 2 cm when comparing with the opposite side.
Where did you measure?
Sir, from the medial joint line, I marked a fixed landmark.
How much?
25 cm.
The swelling extends up to 26 centimeters.
22 cm.
26%, man.
20.
Sorry, above the swelling you measure. So that doesn't take any meaning. The swelling you don't know whether it extends up, whether it is a diffuse margin. Okay. Then
there is no distal neurovascular deficit. There is no lesional lymphadenopathy. There is no regional lymphadenopathy.
Where did you look for?
Sorry, inguinal group of lymph nodes, popliteal group of lymph nodes, and inguinal group of lymph nodes.
Inguinal, which group you saw?
So transverse and vertical, horizontal and vertical groups.
Okay.
Bilateral, there is no inguinal lymphadenopathy.
Okay.
And gait, there is unaided bipedal with bipedal unaided gait with increase in stance space.
What is it called?
Antalgic gait.
Oh, antalgic gait. Okay. Okay.
Provisional diagnosis. Yes, limb length there is no.
So did he check for lungs and did he check for
systemic exam and the abdomen is soft, sir. Bilateral larynx, there is no Krebs service in the lungs.
Very good. That you have to mention. Okay. Provisional diagnosis.
Based on the history and the examination, the provisional diagnosis may be malignant bone tumor arising from the distal femur without neurovascular disease.
Without neuron, right? Okay. Why do you say malignant tumor?
With history of pain followed by swelling, then based on the aggressiveness of the swelling, and for a shorter duration, the patient have complaints. Within 3 months, the patient had a more aggression and rapid progression of swelling. And on examination, the swelling is fixed, and the skin over the swelling is textured and shiny, and
Any increased vascularity? சொல்லு அதெல்லாம் என்னன்னு சொல்லு நான் சும்மா ஒரு க்ளூ தான் கொடுக்குறேன். You have to tell the answer. So what is it? There is? Tell the points for malignant swelling. Local examination, what did you find?
yes, enlarged veins is present, sir.
இதெல்லாம் தான் சொல்லணும். Is it a point in favor or against medical tumor? Enlarged veins, skin is stretched and shiny, enlarged veins, and then each point you think and say whether it is for malignant
irregular border with ill-defined border with irregular surface, sir. Variable in consistency.
Consistency, then. So warm, tender, variable consistency, and ill-defined borders with all this enlarged veins and everything, you come to a malignant tumor, right? What malignant tumor likely? What is the age?
20 years.
20.
You said it is metaphasic.
Yes.
Yes. So only metaphasic.
Yes.
So for the age, what are the metaphasic malignant tumor you think of?
So osteosarcoma, which since it's most common, osteosarcoma, then
This is the common tumor at the age.
second decade of life, it's more common in second.
20 years. So exactly at the end border.
So in the case, what kind of osteosarcoma is common? On that age.
Very conventional take of hospital. Ewing's sarcoma.
Ewing's.
Exactly.
Ewing's is little more younger. It can happen in metaphyseal also, but it has to be little more younger age group. Anything else?
Giant sarcoma.
Giant cell tumor. So what is again giant cell tumor?
Sir, the involvement of epiphysis, sir. Giant sarcoma usually involves epiphyseal region.
So here it is not involving epiphysis. It is more in the metaphyseal region. Okay. Anything else?
What is sarcoma?
What age is that?
30 to 40 years, sir.
Little younger, little older. What? What do you want to do?
First, confirm the diagnosis by basic investigation and
What investigation? Don't keep on beating around the bush.
sir, routine blood investigation, sir.
Okay.
And see X-ray of the local.
First, the patient comes to you, walk to you, you'll just go ask them to go and do a blood investigation and come back again.
X-ray.
If you are an orthopedic surgeon, first you have to say, don't in the examination say routine blood investigation, hemoglobin, blood TCT, CSR, CRP, ESR. Okay, don't say all those things. Right.
X-ray of a local part.
Yes. You're coming, I already screen share. Okay.
Is plain X-ray of plain X-ray showing distal end of knee joint and the distal end of the femur with lesion over the metaphyseal region of the distal femur with narrow zone of transition and
Narrow zone of transition. My God.
wide zone of transition.
Okay. What do you mean by zone of transition?
If we to differentiate whether the swelling is sclerotic or lytic and
So what do you mean by zone of transition? What do you mean by narrow zone of transition?
we can differentiate the normal bone from the.
Very good. What is the involved bone and where is the normal bone? If you can very clearly define, it is called as the narrow zone of transition. If you don't know where that lesion starts, where the normal bone starts, if you don't know, it is called as a wide zone of transition. Here it is
wide zone of
transition. Okay, then.
With
ஏப்பா நல்லா தானே இருக்கு ஆகலையா ஓ ஓ மை காட் allow the share the window. Okay, share screen. Correct. Share entire screen. Your screen sharing. Correct. இப்ப தெரியுதாப்பா வரலையா சரி அப்ப ஏன் வரல என்கிட்ட ஷேர் பண்றேன் சரி அதை காமிச்சிருப்பான் அவ்வளவுதான் சரி நீ ஸ்கிரீன் ஷேர்னே போட்டு வை எப்ப வந்தா வரட்டும் So that is not periaxial reaction. So that is sun ray or so periaxial reaction is where it starts getting elevated. That is what is called as the periaxial reaction. Okay, lifting up of the periaxium. So where the lifting up starts. Okay, so where the lifting up starts. See there, where the lifting up starts. This is where it starts. So it goes up to this. So this is the lifting up of the periasteum where the new bone is being laid. Lifting up starts is periasteal reaction. Okay. So first is what type? The medulla, the cortex. So how is the cortex? How is the medulla? So up to this you are seeing the cortex. So how is it here? You see one by one. Don't directly jump into what is very obvious. You go in an organized way. See the soft tissue, there is some swelling which is happening, so which is increased. You see that there is a soft tissue swelling. And then go into the femur. The lesion starts somewhere here. Up to this you are seeing the cortex. And from here what happens to the cortex? What happens to the medulla? Is it sclerotic? Is it lytic? Whether you are seeing the cortex or not. When did the cancer come?
Cortex is sclerotic.
Cortex is entirely sclerotic. So how is it looking? So how is it here?
Is it most normal to the normal cortex or is it thinned out?
Thinned.
Differentiation. Thinning. Okay. So here you don't expect suddenly to. Here the cortex is this size is okay. Here do you expect this to be like this? So there is some destruction which is happening. Destruction, sclerotic and lytic lesion, not able to see clearly the corticomedullary differentiations. So these are the things which says that it is outside the, inside the bone. There is some tissue, tumor. Okay, then coming to the periasteum. Periasteum, there is some reaction. Then
What is seen in the outside?
now you tell about what is seen in the outside.
Spread is happening in the soft tissue like also.
Yes.
So what is that you call it as?
So what is this called?
So told something.
Yeah. So it is sunburst appearance or sun ray appearance. So what is the reason?
The osteoblastic and osteoclastic activity there is not bone formation and bone restriction.
That is the reason for sun ray appearance. So the vessels which is going, that gets calcified. So that produces perpendicular to the bone. That is the cause for the sun ray appearance. Do you see any triangle?
Corners.
Is it there? So this is the area where you see the triangle. Okay? Where the periostome is getting lifted up and new bone is being formed. Codman's triangle. Then,
Matrix.
okay, so this is based on the X-ray. What do you think the diagnosis?
So is that posteriorly knee examination palpation? Or able to see the entire posterior surface? That's normal, no?
No, you're telling it tumor, circumferential tumor, posterior.
You see the X-ray, it's more on posterior.
So more posterior. Okay, right. So what do you want to do now? What is your diagnosis?
So, malignant bone tumor, probably osteosarcoma of distal
Okay.
tumors.
Right. So with all these findings, metaphyseal region, sun ray appearance, and the Codman's triangle, the wide zone of transition. Okay. What do you want to do?
I confirm the diagnosis by biopsy.
Straight away.
I do MRI to look for any soft tissue involvement, sir. And do CT scan for any skip lesion and cortical.
MRI will give you the skip lesion, not the CT scan. CT scan is for only the bone. MRI is for the tumor and the soft tissue. Okay. So skip lesion and all you will see in the MRI. Right. Everything in the type. Anything else you will do?
To rule out metastasis, I do CT chest with, since more common metastasis is to lung, I do CT chest with contrast, sir. And
why contrast? Why CT chest with contrast? What contrast do you give?
lens.
Huh? CT scan. Don't confuse all the information what you know from the what. Don't tell here. The thing is that you have to say only what you are doing. So when the patient comes straight away, you'll ask for a CT chest with contrast.
Lens CT.
First, you have to take an X-ray chest. What is the common picture in an X-ray chest? If there is a secondary. Cannonball. Tell boldly. Cannonball secondary, you'll see. If you have taken an X-ray chest and it shows cannonball secondary, is there a need to do a CT chest? No need. There is already a cannonball secondary which is formed. If it is not seen, then will you do a CT chest? Yes or no?
Yes.
Yes. Because a less than 5 millimeter secondary, you will not be able to see in the X-ray. You will have to take a CT to find out whether it is there or not. Pulmonary metastasis. You do all these workup and then go in for a biopsy. Right. So any other image is there? So this is CT chest, CT of the limb. Okay. MRI. Okay. Tell. What do you see here?
Sorry.
T1, T2, kernel, triangle, what?
Start saying like that.
Yes.
What for bone is seen?
On the sagittal view, the swelling is more prominent on the posterior aspect and involving the soft tissue. On the posterior aspect, the swelling is more compared with the anterior aspect.
So this is T1 or T2 weighted image.
T1.
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 In T1, fat will appear
Right.
bright. Water will appear dark. So in T2,
The fat will appear there and the water will appear.
so here how does it look like?
T2.
So you see some fluid here and you see the vessel How does it look?
Dark.
The thing here, the fat is dark, the fluid is looking white, so it's not a fat complex.
Okay. Then, so I've seen the extent. Still more, you have to find out the proximal extent and to enter the femur to find out whether there is any skip lesion is there. Because up to this you are seeing the tumor is extending. Okay. Then you have done the MRI. Now you will go for a biopsy. What biopsy will you do?
Sorry. Image guided biopsy. CT or CT guided biopsy.
Why?
Mm.
You can find out which lesion is more active and you can exactly find out. A needle biopsy you have to do. If it is an obvious tumor, you can even do without an image. Okay? So don't shift your attention from here to there. Who is so interesting or giving you any clue there? That irritates the examiner. We will always feel that you are getting some clue from someone else. All the time when you are answering, you are trying to look there. Okay? It has to be subtle even if you are getting a clue. Okay, don't make it so obvious. Here you are not getting a clue, I know, but you are keeping on shifting your gaze, your eyesight. Okay.
What biopsy will you do? Look at biopsy will you do? Where you take the biopsy? Center of the lesion, periphery of the lesion, image.
So,
Which we are playing.
plane is intra-compartmental, so we got go.
Which plane? Anterior, medial, lateral. If you go to take a biopsy, you have to plan for the surgery. Surgery is incision also. Where go to the surgery is that the area is supposed to go to biopsy. So if we take the periphery, so that is the growing into the tumor, so we get cells. So the center will have necrotic tissue. So like to get necrotic. Take the periphery of the tumor and go and the same way go to the incision. So probably tomorrow it's going to be a relevant tumor. You can incorporate that site. So when you're putting a biopsy needle, so you have to go where you're going to put an incision. I mean, future incision. So in case it's going to be a turn out to be a malignant tumor, so you will remove the sinus, tract along the tumor. So that is the way you're supposed to do. And take it to the periphery so that you get a good amount of cells there, so you can very well diagnose. Center will be a necrotic tissue.
Understand? So you have to be from the periphery, not from the necrotic tissue. Needle biopsy, take 4 and then send it for biopsy. Right. It comes out to be osteosarcoma. What do you want?
Sorry. Since this is an aggressive tumor, we downgrade the tumor by neoadjuvant chemotherapy with currently 3 or 4 drug combinations used. Normally methotrexate, cisplatin, adriamycin, and ifosfamide is commonly used. We use 3 or more drug combination for 3 or 4 cycles pre-operatively. Then we plan for a surgical excision with custom-made prosthesis or custom-made prosthesis. After surgery, we can plan for adjuvant chemotherapy. Yes.
So what will you do to the specimen? What you are excising? You assume that it is limb is salvageable. First you want to confirm the diagnosis. Once your diagnosis is confirmed, you have to sit together the tumor board where the pathologist, the medical oncologist, surgical oncologist, the entire team will be sitting and then managing, developing the plan, giving a neoadjuvant chemotherapy. Once it is done and you think that the limb is salvageable, you resect the tumor. What will you do to the resected tumor?
Margin. We have to look.
Margin. Okay, very good. Whether the margin is clear, right? Then
There's one new idea that we know.
Yes.
Anything you do with that?
Tumor. Whether the tumor.
correct. Tumor necrosis.
Is increase.
So you have to see how much of tumor has necrosis. So there is a criteria. There is a PUAS criteria. So you check in high power field. How much of tumor necrosis? Under high power field, check whether it is 50%, 50 to 90%, 90 to 90 or 95%. So based on the amount of necrosis, you can decide whatever chemotherapy you have given, 2 or 3 cycles you have given, whether it is acting or not. If it is active, then it is more than 90%. Then you continue. If it is resistant, then you have to change the chemotherapy. Okay? I think we had, you did very well. You presented the case very nicely. We had a very good case, 2 interesting clinical cases, 1 traumatic tumor cases. I hope that people who have joined us logged in, it was useful, and we'd like to continue this. At this moment, I thank immensely Professor Vijay Narasimhan, who has come all the way for giving his input, valuable inputs, and sharing his wisdom. Thank you so much. I'll honor.
Thank you so much, sir. Thank you for inviting me to be here. Very good chat with you. Really, you have very good cases. You're lucky to have very good cases, and every session you have very good cases to look at program with. If I do this meeting topic getting telecasted, people who are interested can log in the link and really see this. So, in fact, I expect my postcard today to log in and read this link because they visualize what it is here. Very useful blogging session has continued, and all the wishes to you.
I thank the person for the and giving his valuable input. He is the president of the Madras Orthopedic Society.
Thank you.
So I thank Professor Pasupati for joining us. He is the president of the Madras Orthopedic Society. Also, we have the treasurer, Dr. Ponraj, who is here, joined us for this program. I thank very much. Few words.
It is a very interactive session, and we will get a lot of information from each aspect. One professor alone taking a class is different. This is 3 or 4. It's almost like a mimicking the exam scenario, and the candidates also will have an opportunity to fearlessly talk in the forum. So this is a good way of. I appreciate the initiative. Already it is going very well for the past 2 years now. More than 2 years, yeah. I thank Professor Sengar for giving me this opportunity. Thanks.
So now I'm very happy to honor Professor Vijay Narasimhan, who has come all the way. And I also, before I close, thank Corona Remedies for joining with us and doing this program. Thank you. Thank you.